Hello, everyone.
Dr. Ho, time is up.
Yes, sir. Should I
Oh, one
share my
moment.
screen?
No. Wait for the chairman. Dr.
Okay.
Ho, yeah, you may start.
Okay, hi Timothy. So
No problem.
everybody's been admitted already. Yeah. So I will start the session. Good morning, good afternoon, and good evening, everyone. Depends on where you are tuning in from. Welcome to this APSC Cloud Forum. Today's discussion will be focusing on decision making in valvular heart disease. Next slide, please. Join us in this symposium if you are interested to learn about advances in surgical and transcatheter interventions in valvular heart disease, how these advances have created decisional dilemma for cardiologists in the front line managing these patients with valvular heart disease, and how we can utilize best evidence to select the best treatment for our patients. Today, we have key opinion leaders who specialize in valvular heart disease to share their experience in surgical versus transcatheter management of valvular heart disease conditions, such as mitral stenosis, regurgitation, aortic stenosis, and regurgitation. Each sharing will be about 20 minutes, followed by a 5 minutes Q&A. So if the audience have any questions, you may raise your hands or type in your questions within the chat. We will try our best to answer your queries. The sharing will be supplemented by recorded cases. My name is Dr. Ho Kei-Wen from Singapore. I will be chairing this session together with my co-chair. Next slide. Professor Nai Sing Chi from Taiwan, National Taiwan University Hospital. Dr. Chi is a surgeon, so we get a very balanced view. So next slide. Before we get started, some housekeeping reminders, and also that the content of this webinar will be made available on the APSC Cloud, Facebook, as well as YouTube page. Okay, so next slide. Without further ado, let's get started. And next, I now invite our first speaker, Dr. Javed Shaikh from Pakistan. His topic will be on rheumatic mitral stenosis, PTMC versus surgery. Dr. Shaikh, the floor is yours.
Thank you. Thank you very much, sir. I'm going to share my presentation here. Am I visible to everyone?
You can see it perfectly, but you need to maximize your screen. So if you play the...
Okay. Is it okay?
You need to just click on the icon for the presenters mode, the presentation mode.
Okay. Is it visible?
Visible only on your editing mode, not the presenting mode. So
Okay.
Yeah.
It's still in editing mode. Is it okay now?
At the moment, we can't see your screen. Maybe you could reshare
Okay.
again.
I share it again. Is it okay now?
And maybe click the orange play icon towards the bottom of the screen.
Okay. I think, is it okay now?
Perfect.
Okay. That's really wonderful. I'm starting my presentation. First of all, I would like to say and pay thanks to esteemed team of Asian Pacific Society of Cardiology and Pakistan Cardiac Society for their collaboration and giving me this opportunity for demonstration of rheumatic mitral stenosis for PTMC or ACMVR cases regarding my strategic point of view. So thank you very much. It's really an honor and privilege to be here. I am Dr. Javed Khurshi Sheikh, working as a consultant interventional cardiologist and in charge SICD Sakhar, Sindh, Pakistan. So, first of all, before starting my topic, this is a very important debate regarding the mitral stenosis. Mitral stenosis is a very common problem, especially in our part of the world, especially in Asian countries and African countries. According to WHO, there is a prevalence of almost 0.68 to 11 cases per 1,000. This is reported, and this is one of the major cause of the fatalities in a younger population and acquired cardiac diseases. So we are going to discuss about this mitral stenosis, the causes, what are the different causes. The rheumatic heart disease is the most common causes, and it almost comprises of 85 to 90 percentage, and rheumatic heart disease is the cause of the mitral stenosis. So, before starting in a debate in between PTMC and MVR, it is very much important to
Sorry,
take a
Dr. Javed, to interrupt you. We can only see
yes,
your starting slide. I think you may have
yeah,
advanced a few slides, but it's not
yes,
visible. Okay, great.
okay. I am actually just having an introduction, a brief introduction regarding the MVR and PTMC. So that's why it is the only first slide which I have been showing here. Okay, so we are going to discuss about this regarding the procedure. It's very much important to take the history, physical examination, ECG, transthoracic echocardiography, transesophageal echocardiography, and fluoroscopy for a proper strategic profile and for the better management of a patient regarding the percutaneous treatment of a PTMC or a surgical treatment of MVR. So history is very much important. In my case, it's at yeah, she's a 21-year female, unmarried, with a complaint of shortness of breath on exertion. She is having pulse of 70 beats per minute, BPs of 110 by 70. Saturation is okay. Height is of 160 centimeter. Aerovascular examination shows a loud S1, loud P2 with a mid-diastolic rate, apex, and chest is clear. The diagnosis was made for the rheumatic heart disease, severe MS with a moderate pH. So this severe MS is very much important. If there is a favorable anatomy, pliable valve, and there's a no calcification, no other thrombus, or no more than mild mitral regurgitation, then this is the best candidate for a PTMC. And absence of and there is an absence of few of a commissures or severe calcification of the commissures. So in this case, these are echo images which has been shown over here. This shows a severe mitral stenosis from this is LA is dilated, severe mitral stenosis, and there's a diastodoming of anterior mitral leaflet. And this is a short axis view, which has been shown here, and it has been showing a severe mitral stenosis. In a apical four-chamber view, one can notice the fusion of the leaflets. And this is a color Doppler which has been showing a restricted blood flow from the LA to LV. This is an echo report. What we have been doing in our institution, we have been determining and assessing the patient history, clinical examination, and XHS and echo. Echo has been showing and assessing a different scores like a Vulcan score. That's the most commonly used, and Hunks score, that is actually immediate outcome prediction regarding the PTMC, and commercial calcification score, Satura score. These are most important scores which actually determine the probability of the patient for opting MVR or PTMC. So in this case, it was a favorable anatomy having a planimetry by a 0.78 centimeter square, and by a pressure of time is a 0.9 centimeter square. The mean pressure gradient is 17, and left ventricular volume index is of 134 ml per meter square. There are the different steps. So in this patient, the decision for the PTMC was taken, and there are the different steps of the PTMC. It is actually started by a vascular access, preparation of the septal puncture system and balloon, assessing the hemodynamics, septal puncture, and then assessing and recording the LA after entering our needle and Mullen sheath over there, and introduction of a LA guide wire, dilatation of the groin access site enteral septum is being done, and the introduction of the balloon LA crossing the mitral valve, balloon dilatation, and then the removal of a balloon and wire is most important step, and then post procedure hemodynamics are most important. So after taking the access from the femoral right femoral vein and femoral artery, first of all, it's our practice. We use to measure the pressures via Burma. So it has been shown over here, and it has been measured the RA pressures and RV pressures and pulmonary artery pressures. The from the arterial system, this is a pigtail which has been showing the LV cavity, and the LV EDP is being measured and recorded, and so that it can be utilized and assessed in the next come after the procedure. So how much EDP is being improved, and how much patient's mean gradient is improved. So after taking the pressures and patient, then there's a preparation for a puncture of intertel septum. So the wire of 0.032 is being carried on the left innominate vein, and the pigtail is being over there in the aortic root. So this has been shown here. After putting this wire or over this wire, the system of a dilator and Burman dilator and a Mullen sheath, and along with the broken bone needle is being introduced through the femoral venous system. Firstly, what we have been doing, firstly, fully insert this transseptal needle until it tip extends beyond the dilator tip. And then this needle is then withdrawn until its tip is aligned with the dilator tip. Notice over here, this is a pointer and this is a finger which is used as a stopper. So it is pulled back further. This needle is pulled back fixed. So this needle tip is concealed slightly 2 to 3 millimeter from this dilator tip. And this index finger is fixed as a stopper on the needle between the direction indicator and a catheter hub to prevent this needle from moving forward and injure the surrounding parts. This is a 270-degree curve of a Mullen sheath having a length of 59 centimeter. 8 more centimeter length is dilator, and then 4 centimeter more is of broken bone needle. It's actually a 21 gauge needle, and this is a pointer hub. When this system is being introduced in the body, this pointer is actually kept at the 3-0 position. And after that, as it is shown here, in our case, the system is as a broken below needle, dilator, and sheath, as it has been kept in the left innominate vein, and from there, this broken below needle is being introduced from the groin, and it should always be done under the fluoroscopy. Otherwise, it can puncture the Mullen sheath and injure the surrounding tissue. So what the pattern is actually being utilized, for the proper puncturing of the interarterial septum, we will use staircase movement, which has been done by Shaw et al. EpiView. There are the different dips from this innominate vein to SVC to RA is the first dip is filled, and the second dip is filled over here at the aortic root level, and then the third dip is filled at the fossa ovalis level. So our target is to puncture the interarterial septum at the fossa ovalis. So here is the demonstration of this. This is the movement from innominate vein from SVC to first dip to RA, and then at the level of the aortic level, and then goes down at the fossa ovalis level. And one can feel here the dips over here. So you can see a jump from this aortic root level to fossa ovalis level. So these are the landmarks for the septal puncture. It should be kept in mind. Otherwise, there will be no proper transeptal puncture there, and it may injure the surrounding tissues. So the right coronary sinus at the upper end of the tricuspid valve is a very much important landmark to be remembering. The vertical hemline, horizontal hemline, and puncture key point should be the target. These are the optimal puncture landmark site landmarks. For this, the vertical midline and horizontal M line plays a very important role. These are actually imaginary lines, and these lines are actually done by an method and modified fluoroscopic Hunk's method. And this target site is for septal punctures, as a rule, is located at the intersecting point of the vertical midline and horizontal M line. So how does it happen? It is actually done in a RO view. This horizontal M line is being drawn. This is actually imaginary line kept in mind, and this imaginary line is being taken in a RO view. And after this LV gram, when there's a LVOT, the midline is midline horizontal M line is being drawn up to the T10 level. It is done in a still frame of RO view. And this is the second imaginary line. This is a vertical line which is being drawn from a horizontal line is being drawn from this pigtail into the aortic root, and then it's a lateral border of the LA, and the midline is being drawn. So keeping these both lines in mind, like in this view, in RO view and frontal view, these both are imaginary lines. This line is being drawn over here, and the midline, which has been done in the frontal view, the point where this vertical line and this horizontal line meets, this is an optimal puncture site, P point. So it can be confirmed by staining the septum. As we all know, the interatrial septum is actually curvilinear in nature. So we can use a septal flush method to make it confirm that it is in the right direction and right point. So this is a lateral left atrial silhouette, as we have already drawn in mind. So this is a maximum optimal puncture position, which is actually fossa ovalis, which facilitates balloon crossing and minimize the residual transseptal shunt in the future. So in our case, this puncture was done here, and it has been confirmed by the needle entry into the LA. It has been This LA entry is being confirmed by a contrast. It can be more confirmed by by the LA gram of a chamber, and along with measuring of the pressures, and as well as the oximetry and oxygen saturation step up, because this needle is going from right system to left system of the heart. So that was there's a step up in oxygen saturation. So this can be confirmed. After this puncture, when this needle is introduced, as one unit dilator and Mullen sheath is being introduced, by keeping this needle firmly held over there and just pull inside in the left atrium with along with the dilator and Mullen sheath. As the dilator enters in the left atrium, then dilator is unlocked along with a needle. It has been kept over there and firmly, and then this Mullen sheet is crossed through the intertidal septum into the LV cavity. So we can see in RO view, this is a Mullen sheet placed over there, and the dilator and needle is being withdrawn. After this sheet into the LA and confirmation of this LA, wires being introduced. It's of a 0.025 wire, which is actually usually available in the PTMC kits. So this LA wire is being over there, and this Mullen sheet is being removed. In the meanwhile, the another balloon, which is actually usually done over here in our practices and our institutions, as it is safe in approach, and nowadays it has replaced the double balloon technique and multi track techniques. So multi-track balloons. So this another balloon is safe to use. And the meanwhile, when this LA wire is inside the LA cavity, and the intertidal septum and the groin are being dilated with a dilator over there, in the meanwhile, the balloon, one of your colleague is actually makes the balloon prepared for a introduction. So this is a balloon catheter having the main stop cock and ventilator cock, and this is stylet, and these are a dilator which comes with the set, and this is syringe, dedicated syringes available in a kit. This is our 24, 26, 28, and 30 sizes available, and it says a ruler for confirmation. This ruler has been utilized as balloon is being tested outside the body, and filled with a contrast. So the balloon always go for in a sequential inflations. First, there are the three parts of the balloon. First is the distal part is being inflated when this contrast is injected, and then the proximal part is inflated, and then afterwards the inflation of a waste and disappearance of waste at the mitral valve when it is being pushed pushed with a contrast, which is actually filled in the syringes up to the balloon sizes. So balloon size is most important. It is actually usually standardized by a patient site. And this patient's height along with this Hunk's formula, which is actually of 0.1 centimeter into height plus 10, or 160 centimeter. If the patient's height is 160 centimeter divided by 10 plus 10 is equal, the balloon is of 26 millimeter. So this balloon has a capacity of up to plus or minus 2 balloon diameter changes along with these different sizes of the balloons, and it actually depends on the different heights. So it is most important to select the appropriate balloon for a patient. So this is a case, and when balloon is being introduced in the body over this LA wire after dilating this intertidal septum and as well as groin area, this balloon is over there, and there are the two tubes which are actually attached with the balloon. One is an inner tube which is actually available with a golden hub, and the second is this balloon stretching tube which actually stays in the balloon. When this balloon is actually introduced into the LA cavity, and when it reaches the intertidal septum, crosses the intertidal septum, this silver hub is being unlocked, and then the balloon is pushed inside the LA over the curved wire. And then afterwards, the golden hub is unlocked, and which is actually of inner tube, and then this balloon is being pushed into the LA more up to the level of the 6O angle. So it should be flexing over there into the LA properly. So this is one of the video which has been showing how this balloon actually goes inside the body. It's atrial septum, and this atrial septum being crossed, balloon is being crossed, and the gold stretching tube and the gold silver inner tube and golden inner tube is being opened, and after that balloon is being pushed inside by holding these tubes by one hand and by pushing the balloon with the other hand. So there should be a controlled movement, and it should never be done forcefully. So this selection is very much important when the pliable valve is over there, as we have taken from the history echo and transesophageal echo. The reference size and whatever the size of the balloon is actually measured with the PTMC balloons, and then the calcified and severe subcellular disease, it can be reduced to the reference size. So these are the 4 points where one can feel the resistance. It is actually one can feel the resistance at the level of the iliac vessels, and at the level of intertidal septum, at the level of width of the stylet from the curve and the direction of the tip of the stylet. So this direction, when this balloon is being tried from LA to LV, it should be in the direction of the orifice to apex direction in LV, rather than it should be freely floating rather than stucking in somewhere in cardi or in other structures. So these the different methods to cross the mitral valve. It actually depends on the size of the LA, how much size of the LA is, and how a low puncture is done. And there are the different other methods like vertical, direct, and sliding posterior loop method can be utilized. Most frequently, vertical method is used. If there's a large LA, we can use the reverse loop method as well. So this is a stylet positions which has been showing, and the position can be changed, and shape can be changed of the stylet according to the higher low puncture. So when this balloon is being crossed, always assure there's a free balloon movement to the LV, and it should not be sticking into any structure like cardi, papillary muscle. Otherwise, when we are going to inflate the balloon, then it may rupture the papillary muscle and cardi, and patient go into a acute MR and may symptomatic on the table. So balloon crossing is usually done. The RO view, angiogram will help locating the mitral valve. This bobbing of the balloon, which when this balloon is actually over in the LA, it actually indicates this bobbing indicates it's facing towards the mitral valve, and the ventricular ectopics shows entry into the LV, and following the aortic pressure indicates the balloon obstructing the mitral valve. So as we discussed previously, the distal part is inflated first, and then the proximal part, and then the vest. So this is in our case. This is a live demonstration. In our case, the distal balloon, when it is free in the LV cavity, the distal balloon is being inflated by injecting 1 to 2 ml of the contrast, and then it's slightly pulled back. It should not be hard enough to pull it back through the mitral valve. It should be slightly gently pulled back so that it feels an resistance over at the level of the mitral valve. So as it is, this resistance is being made over there, then the proximal part of the balloon is being inflated, and we can see here there's a inflation of a third part, and this waste is being vanished away. So luckily in this patient, when we went for the procedure, we got two procedure done the same case as in the vertical uh, crossing of the mitral valve. Okay, crossing across the mitral valve, and then is a posterior lumen. As we already know, this was a large atrium, LA, large left atrium. So there's a posterior loop method was being done by taking support, and this balloon inflation is being done, and the patient got the maximum benefit of it. As we can see here, after this balloon inflation, this balloon is being popping out into the LA. So it means that it has been sufficiently opened by a balloon dilatation. So this is a last view of a pigtail of ending of the procedure. We can see here by LV gram, and we can assess for the MR on the table as well. So post-procedure evaluation is so much important. As this procedure is being done, where we can assess the symptom improvement, oscillation of the pericardium, like mid-diastolic murmur, decrease intensity, and appearance of the pansystolic murmur may be happening if there is an acute MR. A lung basis patient may go into pulmonary edema. 2D echo is most important, and this is a very important point of view. Every time when this procedure is being done, echo machine should be available in the cath lab, and so we can assess the patient's dynamics and as well as the well at the same time on the table. So the commercial separation, mitral area, MR grading can be assessed, and hemodynamic assessment is important. This is a echo in post PTMC patient, the same patient. So this we can see here, it is opening very nicely in the parasternal long axis view, and this in the short axis view, there's a commissural splitting, and after that in a apical four chamber view, there is a opening of the mitral valve, and this is the color has been showing in this patient. So these are the desired, what are the desired endpoints of the procedure? When should we stop? How many inflation should be done? This is a very important question. And when we are doing this procedure, the aim is to dilate the mitral valve sufficiently so that it can achieve the area greater than 1 centimeter square per meter square of the body surface area. Or when complete commissural opening in at least one commissure or appearance of increase in regurgitation has been observed. So these are the desired endpoints of the procedure. Otherwise, we do repeat this inflation, patient may get symptomatic. There are two definitions frequently implied for a successful PTMC. The final area larger than 1.5 centimeters square and in the value area of the at least 25%, or final area larger than 1.5 centimeters square without MR greater than 2/4. So immediate decrease in the LAP is being noticed. A slight increase in the cardiac index, a gradual decrease in the PAP and PVR over the period of time has been noticed. Complication should ever be kept in mind, and wherever we should be looked, there may be a mortality which is 0 to 3%, and it is usually happening due to massive hemopericardium or a poor condition of the patient at the time of the procedure, how much emergency it is to do the procedure, and hemopericardium may be related to this transcatheter puncture or LV perforation. Embolism of a coronary arteries, cerebrovascular arteries, and air embolism can happen in severe MR in 2 to 19% of the patient. Other resolutions, vasculocomplication, arrhythmias, and piercing of this aorta, RA, and atrial stitch can be happening as a complication. This is a very important complication. This must be kept in mind when there's a large LA or giant LA. This stitch effect happens in the PTMC when this puncture is being done, and all the balloon, all the accessories and balloon are being taken. The balloon, this mitral valve is being dilated. After taking these accessories out, there's a hemopericardium involvement, and there's a cardiac tamponade happening in this type of a patient, because in giant LA, when this puncture is being done inadvertently over here, there's actually invagination of the pericardium, and this may pierce this pericardium from RA to LA. So this is the most important complication. It must ever be kept in mind. In conclusion, this narrow balloon technique was being introduced, and PTMC was done by introduced in 1984 by Innovate et al. It is a minimally invasive, non-surgical procedure, safe, effective therapeutic modality, percutaneous treatment, equivalent and comparable to surgical commissurotomy with successful balloon engagement is generally twofold into the mitral valve area and dominant fall in the transmittal gradients, left atrial pressures and pulmonary artery pressures. It leads to improvement in the patient's symptoms and exercise tolerance. The really results, long-term results are excellent, especially when the acute results are optimal in the presence of the good valve morphology. Thank you very much for
Thank you,
patience.
Javid, for the excellent, very detailed talk. In the interest of time, I'm just going to ask you one very short question.
Yes,
Are there patients in rheumatic heart mitral stenosis that you will still send for surgery rather than PTMC?
Sir, in our setup, in our institution, we usually assess the patient properly by history, fluoroscopy, and by transthoracic echocardiography and transesophageal echocardiography. If there is a severe commissural calcification, severely calcified valve, and large thrombus, and then afterwards there's a more than mild mitral regurgitation, most of the time those patients are being referred for a surgery, and the surgical backup and surgery team is available in our institution, etc.
Thank you very much. Okay, so
Thank
maybe, Javid, I can ask you to stop screen share. In the interest of time, we'll move on to the next speaker. Thank you so much for your sharing.
you, sir.
Okay, we now invite Dr. Ken Tan from the Chinese General Hospital in Philippines. His topic will be on primary severe mitral regurgitation, surgical versus transcatheter edge-to-edge repair. Kent, the time is yours.
Thank you, Prof. I'd share my slide. Are you able to see my slides?
Perfect.
Good morning, everyone. And also, I would like to thank the excellent men and women of APSC for giving us the opportunity to be able to share our experiences with it in terms of the interventions that are available for the different valves that are in topic today. So my talk will be on the strategic imaging and decision-making in mitral transcatheter edge-to-edge repair for severe primary MR. So I'm an interventional cardiologist from the Philippines. So primary mitral regurgitation or degenerative MR is fundamentally a disease of the leaflets, often due to prolapse or flail from chordal rupture. This often falls under the Carpentier type 2 classification. When left untreated, it leads to a predictable and harmful cascade involving left ventricular dysfunction, atrial fibrillation, pulmonary hypertension, and ultimately increased mortality. Surgical repair remains the gold standard for operable patients, but as we all know, in clinical practice, many patients, especially the elderly or the frail, don't qualify for surgery. That's where the M tier comes in. So by mimicking the surgical edge-to-edge repair first done by Dr. Alfieri, the M tier has now been performed in over 150,000 patients with primary MR. But what makes it truly strategic is not just performing the procedure. It's about selecting the right patient, guided by the multimodality imaging and a collaborative heart team. So guidelines on the approach of primary MR have evolved, but up to date still reflects a more cautious stance. The 2020 ACC-AHA guidelines give a Class 2A recommendation for M tier in patients with severe symptomatic primary MR who are at a prohibitive surgical risk and with favorable anatomy. The 2021 ESC guidelines are a bit more conservative, offering a Class 2B recommendation for the same indication. So whenever multiple options for intervention for primary MR is considered, a multimodality team discussion is mandatory. So to reach the best possible care for the patient. So a multidisciplinary team would involve a heart failure expert, an imaging expert, a valve expert, an interventional cardiologist, a cardiothoracic surgeon, and other specialties. So the safety and efficacy of the utilization of transcatheter mitral clip device is in the treatment of primary MR was shown in the Everest 2 trial with its 5-year results published last 2015. So its key findings include that MitraClip was associated with significantly fewer major adverse cardiac events at 30 days compared to surgery, and it is primarily driven by lower rates of bleeding and blood transfusions. At 5 years, surgical repair was still found to be more effective than clipping at reducing mitral regurgitation. However, patients in the MitraClip arm who required reintervention or achieved a similar degree of MR reduction in the next stage fared the same with the surgical group. So its final results showed that there was no significant difference in the rates of death or stroke between the two groups at 5 years. Another more recent study, the REPAIR MR trial, which is still currently going, will determine the safety and effectiveness of transcatheter edge-to-edge repair with the MitraClip in patients with primary MR who are at moderate surgical risk and are candidates for surgical MV repair. So it is a multi-center randomized controlled trial, and its design and rationale was published early in 2023. It is said to have an initial report by next year. So unlike the initial Everest trials, the trial focuses on patients with moderate risk primary MR. So this is a critical distinction as current guidelines reserve M tier for patients who are at high risk or prohibitive surgical risk. So the trial is designed to determine if MitraClip is non-inferior to surgery in terms of composite endpoints of death, stroke, or reoperation at 2 years. The REPAIR MR trial is a critical strategic point that could potentially expand the indications of M tier in the future, and the results will help guide decision-making for a broader group of patients and may shift the landscape of PMR management. So that said, in clinical reality, we often see patients who fall in between. The elderly, the frail, maybe with prior surgery or comorbidities, or M tier becomes a practical lifeline. And in these cases, imaging becomes our compass. It doesn't just help confirm eligibility, it guides our entire strategy from device sizing and trajectory planning to predicting procedural success. So imaging is not just a diagnostic tool, but it's the basis of our decision making. So this figure summarizes key echocardiographic predictors of feasibility for transcatheter mitral valve repair. On the left, we have the most favorable scenario. We have a flail or a prolapsed leaflet located at segment P2 with no calcification, adequate mitral valve area of more than 4 centimeters square, and a mean gradient of less than 4 millimeter mercury. The flail width and the gap are within the ideal ranges of under 15 and 10 millimeter respectively. This anatomy is highly feasible for M tier and typically yields excellent procedural outcomes. In the middle, we see intermediate anatomy, wherein the pathology is located in either P1 or P3, with calcification sparing the grasping zone, and is slightly reduced valve area of an elevated gradient. So these cases may still be candidates, but the procedure becomes more technically challenging. On the right, we have an example of a Barlow's valve, which have severely redundant and thickened leaflets with widespread involvement, including the grasping zone. These are poor candidates for M tier due to the elevated transmitral gradients, small valve area, and excessive tissue mobility, all of which will increase the risk for complications and procedure not being successful. So this slightly busier table lifted from the 2020 AHA valve guidelines describes further the location of leaflet pathology as an important predictor of M tier feasibility. Certain features predict technical difficulty or poor outcomes will include the commissural involvement, severe leaflet or annular calcification, and mitral stenosis as previously mentioned, particularly when gradients exceed 5 millimeter mercury. So this slide illustrates various examples of mitral valve anatomies as seen on TEE, each demonstrating different levels of complexity for transcatheter edge-to-edge repair. So the top row shows a favorable case, a flail posterior middle scallop P2, clearly visible on the long axis and the bicom and in the 3D en-face views. This central lesion with adequate leaflet length and mobility is ideal for M-TEER, often allowing successful MR reduction with a single centrally placed clip. In contrast, the middle row presents a more challenging anatomy with the long axis view showing no significant prolapse in the central segments, but in the bicom and 3D view shows a flail P1 and P3 scallops. So despite this complexity, the diastolic mitral valve area still measured 4.8 centimeter squared. So this still provides sufficient space to place devices in both the commissural regions if needed. So finally, the bottom row demonstrates a prohibitive anatomy wherein there is severe annular calcification as highlighted by this yellow arrow and the flail P3 segment in blue, the arrow in blue. The mitral valve area here is only 2.8 centimeters squared, well below the 4 cm squared threshold. Proceeding with M-TEER in this case would carry out a higher risk of iatrogenic mitral stenosis and would likely be contraindicated. So this slides presenting the other side. This slide summarizes how surgeons assess the feasibility of a durable mitral valve repair. The most ideal anatomy involves an isolated posterior leaflet disease, the absence of leaflet or annular calcification, and a thin normal salvalvular apparatus. So these are the classic, what we call slam dunk repair cases with excellent long-term outcomes. Cases with anterior or bileaflet involvement, mild calcification, or diffuse leaflet thickening represent a more challenging group. The repair is still possible, but depends heavily on surgeon expertise and experience. Relative contraindications would include severe leaflet or annular calcification, Barlow's disease with thick redundant leaflets, type 3B mechanisms with severe tethering, redo surgeries, radiation, valvulopathy, or congenital abnormalities make repair far less likely to succeed and favor replacement instead. So comparing this to the M-TEER table, we see some overlap, but also important divergence. What's favorable for one therapy may not be ideal for the other. So this is exactly why imaging and heart team deliberation are crucial in choosing the right therapy for each patient. So the series of TE images illustrate varying forms of primary mitral valve pathology and their associated likelihood of achieving a durable surgical repair. So in the top row, we see again an anatomy highly favorable for durable surgical repair. The leaflets are thin and pliable, and there's a clear torn chordae involving the posterior middle scallop, the P2, visible in this bicom view in the blue arrow, and then the 3D en-face view in the yellow arrows. So this isolated segment pathology with preserved leaflet quality and normal annular structural predicts a high likelihood of successful and durable surgical repair. The middle row represents a more complex but still repairable scenario. This is an extensive multi-segment prolapse involving both the anterior and the posterior leaflets, with torn cords evident in the central scallops, seen by the blue arrow. The mitral annulus is notably dilated, adding to the complexity, and nonetheless, with experienced surgical hands and proper technique, such annuloplasty and chordal replacement, this pathology remains to be repairable. In contrast, the bottom row depicts a case with the poor surgical substrate. There is extensive calcification involving both the annulus and the leaflets, leading to a restricted leaflet mobility. The 3D transmitral gradient also showed to be at 14 millimeter mercury at rest, even before intervention. These features indicate not only challenging surgical repair, but also a high risk for post-repair stenosis, making valve replacement a more likely consideration. So I will be showing a case we have recently performed involving a 73-year-old male. His symptoms started 2022 with EC fatigue and dyspnea. Initial 2D echo study showed just moderate MR. However, as of late 2025, there was a worsening of functional capacity despite medical therapy. There was also noted orthopnea and considerable weight loss. Initially, the patient was referred to the cardiothoracic surgery service, but was deemed not a good candidate due to poor nutrition. He was then referred to our team for M-tier consideration. So before committing to M-tier consideration, our team had the following goals. First is to determine whether MR was indeed severe, because as we can see, the regurgitant jet is quite eccentric. So we proceeded with doing a TEE image. In the left-hand side panel is the BICOM view, which shows no commissural calcification. That's a plus for favorable anatomy. The initial 0-degree sweep showed an eccentric regurgitant jet going into the left atrium. So further interrogation, this is a modified short-axis view which showed the anterior directed MR jet, which is visibly severe. There was no thrombus also noted in the LA appendage. So here we see a Doppler signal of the pulmonary vein systolic flow reversal, which is an indication of severe MR as well. Speaking with the multidisciplinary team, the team has concluded that the patient may benefit from M-tier. Hence, the procedure was planned. So on further TE examination, doing an X-plane between the BICOM and the long axis view, we are able to make 3D imaging, 3D image the ANFAS view or the surgeon's view. So here, we measured the posterior leaflet, which was quite lengthy. And then the mitral valve area was noted at 4.6 centimeters squared, another plus sign for the favorable anatomy. The flail gap, which is visibly less than 10 millimeter, and there is no significant flail width noted. So far, anatomy seems to be favorable for M-tier. Measuring the LA size to predict the height that we can achieve also showed significant, we have ample height. So the M-tier procedure was performed. So once the transeptal access is achieved, under continuous TEE and fluoroscopic monitoring, the steerable guide catheter and then the clip delivery system are gently advanced into the left atrium. So this meticulous guidance is essential to avoid inadvertent contact with the left atrial appendage and then the left atrial free wall, which could lead to complications. So following the checking of device trajectory, the mitral clip arms are carefully opened within the left atrium and precisely aligned perpendicular to the coaptation line of the targeted valve scallop. So here we see that the prolapsing posterior leaflet is at the P2 segment as well. So this critical alignment is best confirmed using the 3D ANFAS view. So here, the arms are now partially closed as the device is advanced across the mitral leaflets into the ventricle and then reopened below the coaptation point. So the leaflet grasping is monitored using the TEE, and we then confirm adequate leaflet capture by looking at the septal bounds and then the formation of the stable tissue bridge, ensuring sufficient leaflet insertion into the clip arms. So this is essential to prevent complications such as leaflet device detachment and clip embolization. So here, following the device closure, we see a double barrel mitral valve orifice, which is ideal for, which is a good sign for us to know that we have targeted the correct location. And then we committed to finally release the device. So final release showed the reduction of MR to mild MR at the location of the tissue bridge. So doing a surgeon's view also confirms that the MR is indeed just mild at the center. And we are hopeful that with the fibrous tissue formation in the future, this MR will still reduce. So this is the discharge TEE, wherein seeing that the mitral regurgitation is just mild. Mitral valve gradient was at 3 millimeter mercury as well. So in summary, transcatheter mitral edge-to-edge repair has established itself as a highly effective and safe option for patients with severe primary MR who are not candidates for surgery. When guided by a comprehensive imaging and performed in patients with favorable anatomy, MTEER provides a durable MR reduction, symptom relief, and improved quality of life. The evidence from the Everest-2 trial, supported by real-world registries, reinforces its use in high-risk individuals. And importantly, MTEER is not a replacement for surgery, but a complementary therapy within a broader patient-centered decision framework. And as the repair MR trial matures, we may see its role expand into intermediate risk populations as well. For now, success depends highly on strategic planning, anatomical insight, and heart team consensus. Thank you very much.
Thank you, Ken. That was an excellent, very clear, very comprehensive presentation. We now have about 3 minutes. I open this time for any Q&A for Kent. Maybe, Kent, I can start the ball rolling. I'm sure you see a lot of such patients, young, 50 years old, low surgical candidates, severe MR, slam dunk, ideal pathology for clip. Seen surgeon doesn't want to do surgery, wants clip. What would you tell these patients?
Firstly, a full exposure of the current limitation of the clip should be informed to the patient. By studies, we only have 5 years as far as clinical data and observation for these patients. So that should be clearly understood by the patient, and the possibility of surgical intervention in the future or another reclip for the patient should be explained as well. If the patient is amenable for these scenarios, I think clip can still be considered, but it has to be emphasized that right now the data does not show that it is the best treatment for the patient. So surgery should always be emphasized as the top choice first before considering clip for these kinds of patients.
Thank you, Ken. Any other burning questions? Okay, if there are no other burning questions, we will move ahead. The next speaker is Dr. Haditomo Nomi from Shinshu University of Japan. His topic is the management of secondary mitral regurgitation in heart failure with reduced ejection fraction for TEER. Dr. Nomi, the time is yours.
Thank you, Dr. Chairman. So I'm sharing my slide. Is the slide okay?
Can see perfect.
Yes, thank you. Thank you, Dr. Chairman, for giving me such an opportunity to give my presentation here. I start my presentation about MTR for FMR. So I have nothing to declare. So needless to say, the evidence of the MTR is established and the clinical impact of MTR has been so big. On the slide, the Kaplan-Meier curve for 2 RCTs are shown. In the COP trial, severity of MR was severe, very severe. EROA was 0.41. In the ReShape trial, reported last year, MTR showed clinical benefit even for the patient with moderate FMR, EROA 0.23. So let's see the guidelines. Left side, ACCH 2020. Right side, JCS 2025. So MTL now gets higher recommendation for FMR than open heart surgery. So I share the case of 57-year-old male. He had acute myocardial infarction 14 and 1 year ago. His ejection fraction dropped, and 2 months ago, he experienced first acute decompensated heart failure, and he's referred for mitral TR for severe functional MR. His medical history included diabetes and dyslipidemia. So his medication was introduced almost perfectly: beta blockades, SGLT2 inhibitors, circular valve Sultan, and MRAs. And substantial amount of diuretics was also induced. So his NYHA class was 2, STS score was 29% for MVR. So his blood pressure was 101/60, and BNP was 501 picogram per deciliter. So chest X-ray and ECG were shown in the slide. So his LVEF was 33%. Her left ventricle is dilated, and LVEDV was 224, and LVDD was 70. And the diameter of left atrium was 52 millimeters. The etiology of MR was by leaflet ventricular tethering. MR was significant, but not semi-moderate. So ERO was measured 0.33, and regurgitation volume was 48 millimeters. So patient's FMR was moderate to rest. So we did hand grip echo, stress echo, and after 20 kilogram for 3 minutes, he grips the hand grip. MR got worse to severe, apparently. So this is the TE findings. P2 length was 11 millimeters. MR was moderate, 1 TEE. The coaptation was asymmetric to some extent to the posterior. So before the procedure, we measured the height of fossa vallis and mitral valve area. So the TSP site is important. So in the procedure, we need sufficient distance from the mitral annulus. So the patient's distance the fossa vallis to the annulus of mitral valve is 41.7 millimeters. So that's enough. So this is our strategy. To grasp the leaflet prior to the angle of coaptation, we need some aortic hugger. So we plan the puncture site should be mid or superior, and it's posterior. One clip for center of A2P2 will be enough to reduce MR. If not, we consider the second clip for A2P2. So in the FMR etiology, we select NT series more often. Why that clip is better in this wide MR etiology on exercise. So this is the actual image in the procedure. We measure the distance of puncture site to the mitral annulus. There's 3.4 centimeters. That's enough for clip. And we confirm the location of the puncture site. It's mid to superior. And posterior, enough. So we puncture here, and we recheck 3D also, the location of TSP, tenting site. This is the puncture site, tenting site, and this is mitral valve annulus. So high enough from the annulus. So we recheck the puncture site, and here we puncture the septum. So we insert the mitral clip to the LA. So we now advance the system, and we have to steer down the system to the mitral valve. So we have to check the tip of the clip so that this doesn't touch the LV wall. And we add M knob to the mitral valve, steering down slowly. And we control the position of clip by transesophageal echo. So this is the biplane view. Left side bicommissure view, right side LVOT view. And we check the trajectory, direction of the system, just straight for LV and coaptation line. And next, we have to check the protein perpendicularity of the clip direction. So we open the clip once in the LA, and the clips should be 12 o'clock and 6 o'clock. And after that, we advance the clip to the LV once slowly. And open up the clip in the LV and pull the system to pick up the leaflets. And once we miss the posterior leaflets, so we try it again. So this time the leaflets are on the clip arm. So insertion of the leaflet is very good. So this is a key intraoperative TE. Trajectory should be straight forward to left ventricle and coaptation line. And the right side shows the glipper down, the moment glipper down of the clip. So the leaflet is inserted precisely to the arm. So we close the mitral clip, and then 3D image was shown here. So MR was reduced to trivial, and tissue bridge was confirmed. So pulmonary vein flow Doppler is very important in terms of the effectiveness of the procedure. In this case, S wave gets dominant after clip placement. So we rechecked the hand grip stress TTE next day. So the right side, you can see the MR was less than mild, even in the hand grip stress echo this time. So clinical course was very good. Discharge POD3. His intervention class is 1 during follow-up. So in summary, mitral TER has been established as standard of care for FMR patients. The timing of intervention isn't always an issue. 100 grip stress echo is a quick and useful test for the diagnosis of latent but clinically significant FMR. The procedure of mitral TER for FMR is not complicated. Most of the ventricular FMR is controlled by 1 or 2 clips at the A2B2 center segments. Thank you.
Thank you, Dr. Nomi. That was an excellent talk, and we made up a lot of time. We do have a bit of time for discussion, about 15 minutes or so. So we can actually have questions about your talk as well as earlier talks. So now open the time for any questions for Dr. Nomi or any earlier speakers. Maybe I can start off first. Dr. Nomi, thanks for an
Yeah.
excellent talk. As we
Yeah, thanks.
manage patients with heart failure and reduced ejection fraction, there are many conflicting interventions as a cardiologist you may do. You may consider surgery, PCI, medications, which is very powerful at the moment, devices such as ICD, CRT, or even heart transplant and LVAD devices. Many a times, the consideration for TEER for mitral regurgitations often I can see gets pushed to the very last resort. Is that what you see in your center? Are the patients being referred too late? What would be one message that you would give to referring doctors handling heart failure patients?
Patients seems too late.
Yes.
Heart
Are
failure
they referred
stage.
to you too late for TEER?
Yeah. It's very important question. To detect earlier early stage of MR, which is clinically relevant, we should do exercise stress echo. So, but it's not popular in Japan, in many facilities. So, if a patient has a moderate MR and heart failure episode, the physician should refer to the surgery facility, I think. Yeah.
Thank you very much. Any other questions? Or maybe I can direct this also to my co-chair. From a surgical point of view, surgery for treatment for secondary mitral regurgitation in somebody with reduced ejection fraction, how keen are the surgeons to do mitral valve surgery for such patients?
In surgical view, actually, reduce ejection fraction with functional mitral regurgitation. Actually, surgery plays very little roles in these patients because all those trials says that when we do mitral repair or replacement, they don't have benefit for long-term survival. They probably have a little bit benefit for readmission, reintervention, those things. But for patient survival, in those functional mitral regurgitation, using surgery actually had no proven evidence. So I think intervention using TER actually helps those patients with symptomatic improvement without surgical intervention, because surgical intervention actually make trauma for those patients. So right now, those patients actually goes to first is medical treatment. Then if the medical treatment failed, then we can consider the intervention for mitral TEER. And if they failed, finally they come for, in my hospital, they come for mechanical support. If those are reduced ejection fraction with mitral regurgitation become an end-stage heart failure, in my hospital, we will consider a long-term durable mechanical support for them to preserve the end organ function. Then we can have next step for heart transplantations or other end-stage heart failure management like this. So for those surgical mitral repair or replacement in functional mitral regurgitation actually goes decreasing in my hospital in surgical department because we prefer those patients go for intervention for the high-risk patients.
Thank you, Co-Chair. So that's what I see for our side as well. The surgeons are very reluctant to do surgery just for secondary mitral regurgitation, exact points that you have made, unless there are other concomitant indications for surgery. They would generally not recommend surgery just for isolated MR in these patients. Okay. Any other comments or questions?
It's a question
If
from,
not, sure, go ahead, Dr. Khan.
we know that this functional MR is not an indication for surgery primarily. So should we wait for a long time, the LV to dilate, the MR to become severe, and then do for MTER? Or what are the parameters should for an earlier consideration of these patients for MTER?
Maybe Dr. Nomi, can you address the indications on either echo or imaging that may help us guide the timing of TEER?
A time of TEER, earlier intervention, you mean?
Yes, yes.
Okay. So the patients are, if the patients are still symptomatic after optimal medical therapy, and the patient has still moderate MR, so the evidence suggests that MTR is effective for such kind of patient. So the ventricular FMR should not always be severe at rest. So the patient is suffering from the exercise MR or decompensation, the worsening MR at the decompensation. So we need to stress. We need the stress echo in earlier phase and detect the worsening MR at the exercise. So that's the key of early intervention, I think.
Thank you. And is there a difference between Pascal and this mitral clip?
In Japan, Pascal is not indicated in ventricular FMRs, not yet. So we just use mitral clip for ventricular FMR. So DMR for Pascal for DMR. Yeah.
Okay, thanks everyone for the discussion. Okay, so maybe if there are no further pressing questions, we will move on to the next segment. The next segment is me. I'm Kewin from Singapore National Heart Center, and today I'll be speaking on aortic stenosis, changing gear, surgery versus TAVI. Thanks for the organizing committee for asking me to speak on this, and also to make my talk earlier compared to native tricuspid AS so that I can go to my clinic earlier. So I'll now share my slides. Okay, so can everybody see the slides clearly?
Yes.
Yeah.
Yes, okay. So thanks everyone again for the introduction. Critical AS due to bicuspid aortic stenosis. These are my disclosures. So to outline my talk today, I'll give a brief introduction to bicuspid aortic stenosis, as well as an overview of surgical valve replacements versus TAVI for bicuspid aortic stenosis. And I'll finish off with a case example of AS treated with TAVI, hopefully giving everybody a very balanced view between the two treatment options. So bicuspid aortic valve overall worldwide, up to 2%, but in our region, particularly in China, high prevalence of bicuspid aortic valve above 60%. It may be genetically linked, and there is a male preponderance. Both aortic regurgitation as well as aortic stenosis may occur in patients with bicuspid aortic valve. Additionally, there may be ascending aortic size dilatation that may be of consideration when we look at overall management of such bicuspid aortic valve patients. This forms the most common cause of aortic valve replacement in younger patients under 70 years old. We're very familiar with the Sivers classification of bicuspid aortic valve, type 0, no REF-A, type 1, where there's one raphe, and type 2, where there are two raphe. In treating somebody with bicuspid aortic valve, we need to consider that these are generally younger patients. So if we are thinking about valve replacement, we also need to think about durability of such valve replacement, and hence the need for lifetime management, the need for TAV in a surgical valve replacement or TAV within a TAV, if particularly we're treating younger patients. The younger patients tend to have lower surgical risk, and they need perfect results, because these imperfect results, it may be we need pacemaker or patient prosthesis mismatch or a lack of coronary access, would affect from the time they have the intervention to they die. So it's a long lifetime that we need to manage. The other consideration is the possibility of inheritance, the need for screening relatives. We also need to consider not just the valve itself, but whether the ascending aorta is dilated, whether there is a need for root replacement. And we also need to think about what is the risk specific to the patient for TAVI intervention. Is there a risk for embolization, eccentric expansion, paravalvular leak? This may affect our choice of TAVI prosthesis that we have for patients. So this is a busy chart looking at bicuspid aortic valve and management. So if we do have a patient that has bicuspid aortic valve, we may look at whether there is any dilatation of the ascending aorta. If there is dilatation and it meets surgical replacement indication for the root, then it's a good surgical candidate. The patient will go for surgery. If there is no dilatation of the ascending aorta, in a very young patient, generally it favors surgery. Unless the patient has high surgical risk, then we will consider TAVI. On the other side of the spectrum, we have very old patients, more than 80 years old. Even if they're bicuspid aortic valve, generally TAVI will be considered first, unless surgical anatomy is very unfavorable for TAVI, then we consider surgery. In the middle, it's where there is a lot of discussion. If it's very favorable for TAVI and the patient have high surgical risk, clearly it favors TAVI. If it's very unfavorable for TAVI in terms of anatomy and the patient have low surgical risk, then of course surgery. But in between, there may be a need for a heart team discussion to decide which way the patient should be treated. What are the unfavorable anatomy to consider for TAVI? If there's excessive calcium, it may be in the raphe, it may be in the cast, or maybe in the outflow tract or annular calcification. There's risk of coronary occlusion by calcium. If there's severe angulation of the aortic root, in addition to dilatation of the aorta, this makes the TAVI procedure very difficult. So we had to bear in mind that even though there are reports and case series of TAVI successfully treating bicuspid aortic stenosis, early TAVI trials excluded patients with bicuspid aortic stenosis. What are the current evidence of bicuspid aortic valve treated with TAVI? In early trials, we have both balloon expandable trials looking at XT, balloon expandable trial, as well as self-expanding valve. Overall, the procedural mortality for TAVI in bicuspid aortic stenosis was in excess of 3%, with device embolization in such first generation devices, early generation devices, up to 2%, with moderate aortic regurgitation nearing 13%. If we use CT pace sizing, we can reduce down the aortic regurgitation and paravalvular leak to about 15% or so. Of course, with improvement, we have newer devices and better screening technique and planning technique. These combination result in less paravalvular leak in newer devices and more experience, increased success. However, despite the advancement, there is no difference in complications such as stroke, bleeding, vascular complications, and hence. So there is a risk when we treat bicuspid aortic valve patients with TAVI. Some surgical updates. As in tradition, the surgical valve replacement can be of mechanical as well as bioprosthetic valve. The mechanical valve have also improved, such as the Onyx valve with lower INR targets, so that there may be less of consideration in patients with active lifestyle. It is also made perhaps a little bit easier with the availability of sutureless or rapid deployment valve, such as the Intuity or the Percival valve, and Ross procedure, where the roots of the pulmonary is implanted into the aortic site as a surgical option. So these are the updated surgical options for bicuspid aortic valve. So I'm trying to give a very balanced view, not just gearing towards TAVI, but surgery as well. So when we consider the outcome of TAVI versus surgery, we can examine the US database. If we look at a 3-year database between 2016 to 2018 and compare TAVI versus surgery for bicuspid aortic stenosis, primary outcome being in-hospital mortality, secondary outcome being short-term MACE. In this 3-year analysis, we have more than 17,000 patients with bicuspid aortic stenosis, 10% of which underwent TAVI and about 90% underwent surgery. Of these patients, about 1,400 patients were matched and propensity tested. TAVI resulted in reduced in-hospital mortality, similar MACE at 30 days and at 6 months compared to surgery. Inpatient results, TAVI resulted in less in-hospital death, less major bleeding, less vascular complications, less AKI, and less length of stay, 2 days versus 6 days. And as expected, pacemaker implantation is higher, 11% for TAVI versus surgery, less than 10%. 6 months, no difference in all these outcomes, particularly mortality. However, there was still a high risk of pacemaker implantation. If you look at the NOTION trial, this is a randomized low-risk trial that was published in EuroPCR in 2024. Primarily, it looks at low-risk severe AS patients that are young, randomizing TAVI versus surgery. If we look at the overall baseline characteristics, these are relatively young patients with mean age of 71, low risk SES score 1.1, and a bicuspid population nearing 30%. If we look at the overall trial outcome, with the primary outcome of death, stroke, and rehospitalization, TAVI and surgery, no difference. Perhaps a little bit more non-disabling stroke in the TAVI cohort in the overall study population. And as expected, TAVI versus surgery, less major bleeding and less atrial fibrillation, shorter length of stay, as well as increased paravalvular leak and greater patient-prosthesis mismatch in the surgical treated patients. However, if we break down into the bicuspid aortic valve, this is when things start to get a little bit more interesting. Whereas in the tricuspid population, surgery had more patients meeting primary endpoint. In bicuspid valve population, you can see an early separation favoring surgery compared to TAVI in such low-risk patients of the primary endpoint. And if we look at the forest chart comparing tricuspid AS and bicuspid AS, we can see in bicuspid AS patients, it actually favors TAVI compared to treatment of tricuspid AS between TAVI and surgery, particularly when we are considering paravalvular leak and stroke. There are greater incidence of such complications when TAVI is used in the bicuspid population. So it Clinical equipoise, if we look at just low-risk TAVI versus surgery based on this Notion 2 trial overall, but if we break down into bicuspid young low-risk surgical risk patients, TAVI outcomes are less favorable. And hopefully, future trials will tell us whether we should be treating a younger low-risk bicuspid AS patients with TAVI compared to surgery. So now I'll move on to a clinical presentation, a hopefully balanced one. This is a 68-year-old Chinese lady who was admitted with typical heart failure symptoms and chest pain. She had ESM murmur, BNP is highly elevated, and TROP is also elevated. ECG remains in sinus rhythm with LVH changes. Echo, despite an EF of 25%, the heart was still critically stenosed across the aortic valve, generating a mean gradient of more than 80 mmHg. The coronaries were clean, so the coronary artery disease did not account for EF of 25%. It's mainly due to her aortic stenosis. So we were planning for intervention. So we done a CT scan, which confirmed the diagnosis of a type 0 bicuspid aortic valve with heavy calcification. The coronary heights were both more than 10 and not likely to have coronary obstruction with TAVI. The sizing of the aortic valve, we look at the annulus. If we look at the average annulus, it is about 28. So in general, for TAVI, we try to oversize in order to anchor. And when we use a valve size between a 26 and 29, this actually would favor a larger valve in order to oversize. A 26 valve seemingly would undersize. However, in a bicuspid situation, there are more considerations. So we place virtual valve sizes of either a 26 compared to a 29 at various levels at LVOT at the annulus to see where the ceilings may be and whether there may be complications of using too large or too small a valve. And at 3 mm cuts, we evaluate this. We also notice that the aorta is very horizontal and slightly dilated. This actually makes transcatheter aortic valve more hazardous to complete, and the valve is heavily calcified. Good thing is that her femoral iliac access were excellent, so this is not a consideration. She was seen by the cardiothoracic surgeon. She was offered surgery, higher risk, of course, with an EF of 25%, but not prohibitive. Overall risk about 5%. So a young patient, 68 years old, surgeon say can do surgery and reserve the list of surgery for the patient. However, the patient declined surgery. In her mind, her main consideration is finish off with whatever treatment. She heads to US to see her grandchildren. She opted for high-risk surgery. So every day I go to the ward, I give her 1,001 reasons why I don't want to do TAVI for her, but she declined surgery and opted for high-risk TAVI. The plan, therefore, for us is to do TAVI using a balloon expandable valve. In that time, a Sapien 3 balloon expandable valve. We chose a smaller valve in the consideration of bicuspid aortic valve, a 26 rather than a 29 with 3 mm overfilled balloon. So this was the valve procedure. You can see that the baseline aortogram that is horizontal, heavily calcified across the aortic valve, is very restricted in movement. You can see the crossing was not easy in such horizontal dilated aorta. The wire eventually crossed, but the catheter doesn't follow the wire. So we remove the straight wire. We prayed a long while to hope that the catheter remains there, while we switch over to an exchange length wire, hopefully to pass a lower profile catheter, but somehow the AL slipped through when we passed that. This was the balloon with a 20 millimeter balloon. You can see calcification, dense calcification that was pushed to the side. when the balloon is inflated under rapid dilatation and pacing. This was the Sapien balloon expandable valve, undersized 26 valve that was overfilled 3 mm more volume. You can notice the calcification. Notice this calcification. I will highlight this later because this has implications later on. This is a relatively high implant. We are looking at the radiolucent line to be in line with the annulus. We try to have a higher implant in such cases of bicuspid aortic valve. When we are happy with the position, we rapidly pace the patient. Notice this calcium, how it gets pushed to the right coronary cusp. When the valve is deployed and balloon expanded, and it comes down, the balloon comes down. This is the final aorogram. Good results. You can see how horizontal the aorta is, no aortic regurgitation. And the invasive perimeters show an EDP of 21, mean gradients single digit 9. Echo shows a good gradient of mean gradient of 14, and with trivial paravalvular or processus regurgitation, and miraculously her ejection fraction recovered from 25 to normal. She was discharged well from hospital at day 3. If I stop my presentation now, my clinic will be flooded with patients that are young with low surgical risk next day because TAVI can treat bicuspid aortic valve. But I want to give a very balanced view. So I go on. For this exact patient, she represented to the emergency department 2 weeks post-discharge with chest pain in the middle of the night. ECG was as such as there were ST depression, it was previously shown due to LVH. This was the X-ray that was post-TAVI during the index hospitalization, and this was the X-ray of the patient when she was readmitted for chest pain. So why did she have chest pain? ECG, not much changes. This was the reason. Echo showed good cardiac contractility. There was no pericardial effusion, but an urgent CT scan showed ascending type A dissection that originated from the cusp. That you can remember that calcium nodule that you see on the right probably originated where the dissection plane was, causing this type A dissection. So very unfortunate for the patient. An urgent CTS consultation was made. Unfortunately, before anything can be done, she collapsed, and echo now showed a huge pericardial effusion. Patient did not survive the resuscitation and demise. So in conclusion, what I've shown is a very balanced patient's scenario that even though TAVI can be done in certain selected patient for bicuspid aortic valve, we should still consider surgery. Do consider patient factor, surgical, as well as TAVI risk in deciding what's the best treatment option. And if we have to do TAVI, CT planning is mandatory. I thank everybody for your kind attention. I'll stop sharing now and open this time for any questions.
Thank you, Dr. Ho, for your excellent sharing of these patients. I'm a surgeon. I think the reason the patient have aortic dissection after TAVI, of course, is the heavy calcified that injure the aortic annulus and aortic wall that cause aortic dissection in the further follow-up. I think it's not the real bicuspid aortic valve's fault. It's because of the heavy calcification. We have saw some patients with heavy calcification after TAVI. Those calcifications sometimes penetrate left ventricular muscle or even aortic root immediately. So I think patient selection actually we should check out those patients whether they have heavy uneven calcification over aortic annulus, because those uneven or very sharp calcification, we don't know whether those calcification goes to. Some patients, they are safe because the sharp angle of calcification didn't penetrate the aortic annulus. But some patients, they are not lucky. They have a risk of the calcification penetrate the aortic annulus. But this is actually, the procedure actually works very well for bicuspid aortic valve. The patient don't have much aortic regurgitation, and the pressure gradient got soft. So actually, that's still a good procedure, but we should take very carefully about preoperating whether they have uneven or very calcified calcification or even sharp calcifications over aortic annulus. That's my point of view. But still, congratulations for the success of TAVI over the bicuspid valve. That really works well, but we have still need to have a patient selection for those patients.
Thank you, Prof. Chi. Thanks for those comments. I have a question from the audience as well. What are the contraindications for TAVI in such situation when we have bicuspid aortic valve? So there are standard contraindications even for tricuspid aortic stenosis if the coronary heights are low, if there's high risk of coronary occlusion, and if there is unfavorable access. Those will be standard TAVI contraindication. But what is specific to bicuspid aortic valve are those that make the procedures very unfavorable in terms of outcome or increased complications. So that may be high calcification load, if there is very angulated or horizontal aorta, as we can see here, particularly so when there is dilated ascending aorta, that may make crossing as well as delivery of the valve very difficult. A very heavily calcified raphe also increases the risk of root injury. So there is debates whether a balloon expandable valve that is shorter, that may make lifetime management easier for such patient, carrying a higher radial force, but increasing the risk of root injury, versus a balloon expandable valve, which has less risk of aortic root injury, but may make lifetime management a little bit more complex in such taller valve, a little bit more complex discussion. So this issue of balloon expandable versus a self-expanding is still under investigation. Narrative, any comments? You're up next.
Yeah, yes. It is very nice presentation, Dr. Kevin. Thank you for showing us, the impressive case that unfortunately didn't end well. But I think, for me, when I'm dealing with bicuspid aortic valve, I'm concerned about dissection or rupture. First of all, I would not do it if the patient has aortopathy. But I think in some cases, even though aorta is not that dilated, but if the wall is quite thin, I'm still afraid of making dissection like this. So I think it is my concern. Other than that, I think it is about pro and con of TAVI and the risk of surgery.
Thank you very much. Okay, so we'll move ahead. I would have to leave after this for my clinic, and I have my co-chair, Prof. Chi, to take over the discussion. But I now invite exactly Dr. Naratip, who will be doing the next session. His topic will be demonstration on critical aortic stenosis for surgery or TAVI, my strategic thinking. Dr. Naratip, your time is yours.
Good afternoon, Mr. Chairman. Thank you for the kind introduction. So my topic will focus on tri-leaflet severe AS. I have to thank Dr. Kevin again for the great lecture, because it will make my talk easier. I think Dr. Kevin showed us about the detail of the complex procedure. Normally in tri-leaflet, the procedure is more straightforward. So my talk, I will focus on thought process rather than showing you the case. This is my disclosure. I'll start with the case presentation. This is a patient that I saw a couple weeks ago in my clinic. She is a 75-year-old woman presented with dyspnea on minimal exertion for a couple of months. Her past medical history was not that significant, rather than having controlled hypertension and dyslipidemia that she has been taking medications for. However, she had past medical history of subarachnoid hemorrhage that required brain surgery when she was in the 40s, and that left her with some disability. She can walk, but she has to hold her daughter when she walks far. She is 56 kilo and her height is 149 centimeter, standard Thai elderly lady. Body surface area is 1.5. Renal function is normal and she is not anemic. And this is her EKG, sinus rhythm, no conduction abnormality, but she has like 1 millimeter diffuse ST depression along with isolated ST elevation in AVR and some elevation in NV1. Start with the echo. From the parasternal long axis view, we see concentric LVH, normal LV systolic function. And we see limited excursion of the aortic valve with mild aortic regurgitation and mild mitral regurgitation. Zoom in to see the aortic valve closely. From the short axis view, this is tri-leaflet with some fusion between the leaflet. We can see that non-coronary cusp is not moving at all, and also it has some fusion with left coronary cusp, but it's actually tri-leaflet. When we look at Doppler, she has velocity almost 5 meters per second. That results in peak-to-peak pressure of resulted in mean pressure of almost 60, and the peak pressure is about almost 100, and calculated AVA is 0.6 square centimeter. So this is critical, very severe aortic stenosis. So this is the summary of the echocardiogram. Classical severe aortic stenosis with no other valvular heart disease involvement, concentric LVH with normal EF, mild pulmonary hypertension. So as a part of the workup, we perform coronary angiogram, moderate to severe disease in distal RCA, which is heavily calcified. There is no disease in left main and in circumflex. She got very severe stenosis in mid-LAD and 2 tandem lesions in ostial and proximal LAD. So this is a summary of the coronary angiogram. 70% ostial LAD stenosis, 70% proximal LAD stenosis, 90% mid-LAD stenosis, and 70% distal RCA stenosis. So this is my strategic thinking, when I see the patient with severe aortic stenosis. So first of all, I have to answer first if this is real aortic stenosis. In this case, no doubt, the gradient is very high. So it is classic high gradient severe aortic stenosis. Then my next question is, should I recommend surgery or TAVI? And the next one, if the patient has concomitant coronary artery disease, if we choose TAVI, should we do PCI or not? And if we do PCI, should we do it before or after TAVI? The fourth question is, if I do TAVI, should I do balloon expandable or self-expandable? And then size and position of the valve. And of course, when we do the real procedure, we have to talk about the detail of procedure. But, the first 5 questions is something that I have to give the answers before the patient comes to the cath lab to get TAVI. So I think, it is a good discussion, when we have audience from different countries, because although we are all Asian, but I think it is different from country to country. Let me show you about the data of Thailand. Our life expectancy at birth is about 75 years old for Thai men and about 81 years old in Thai women. However, we are going to the aging society. Our growth rate is very, very small, only 0.2% growth rate. But, if you look at the graph, we have almost 1 million Thai people who are older than 90. So I think it's going to be a burden for the whole country. However, if you reach 60 years old, then your life expectancy is about 77 for Thai men and 83 in Thai women once you pass 60 years old milestone. On the other hand, we are a poor country. Our minimum wage is less than 10 euros per day. So that make reimbursement very difficult in Thailand. So TAVI is not in Thailand. So this is our guideline. We have the guideline where and basically, if people, if patients are older than 80 or they have high surgical risk, we recommend TAVI. If the patient is less than 80 and not a high risk for surgery, then we have to do more evaluation about surgical risk. We use surgical risk along with the patient's age and suitability for TAVI. So let's say if the patient is less than 80, like in the patient in this case, and if the patient is moderate risk, we recommend TAVI as a class 1 indication, same as surgical AVR as a class 1 indication. Or if the patient is low risk, but the age is between 70 and 80, we recommend TAVI as a class 1 indication, the same level with surgical AVR. So in majority of our patients, I think we can go either way because it is our reimbursement scheme. For surgical AVR in Thailand, it is fully reimbursable. That's why, in our practice, we have to calculate the risk score. So in this case, she is low to intermediate risk for surgery. I mean, like CAPH plus surgical AVR, STS score is 4.5%, and Euroscore 2 is 3.29%. There are many ways to evaluate patients' frailty, but in our practice, we like to use clinical frailty scale because it is very easy. In this case, she is vulnerable because, from the previous brain problem. I think, she slowed down a lot. So in this case, I think, still operable, but we have to see if the patient is a candidate for TAVI. So in this case, we have to do CTA. So in this case, annulus area is about 316, and we got the area derived diameter of 20.1 millimeter, and the annulus is 18.4 times 21.5 millimeter. LVOT is quite clean, no calcification. Sinus of Valsalva is big enough, 27 in the left side and 26.8 in the right side. STJ diameter is 20.7 millimeter with mild calcification. So I think from the root, it is not that bad. The degree of calcification and the site is feasible. So next step, we have to see coronary height. Left and right is not a problem. Left coronary height is 12 and the right coronary height is 16. Calcification is moderate. Another thing that we should take a look is membranous septum length. it is only 1.3, so it is quite a high risk case for pacemaker implantation if we do TAVI. The angle of the aorta is 57, which is good, not difficult. We can do TF without any problems. The access is good, big enough. So in this case, I think it is feasible for both CABG plus surgical AVR or TAVI plus PCI. But in this case, she could afford TAVI. So I think, it is a good option. There are some concerns, for both sides for surgery. I think the only one concern is poor mobility. Other than that, I think she's also a good candidate. For TAVI, in this case, I would say there are 3 concerns in my mind. First, she has small annuli. 2, she has concomitant coronary artery disease. And, she's quite young for Thai standard. I think, like I showed you, we have many patients, many people who are older than 90. So if we do a TAVI when she's 75, I think we have to make a plan, in the next 10 years. Once she's 85, she might need a second valve. So let's talk about TAVI or surgery first. I think, before last year, in our TAVI trial, I think women underrepresented. And in women, when we do intervention, usually they have higher risk compared with men. That's why, we need more data for women. And we got the answer from RIA trial that studied the women with symptomatic severe AS and randomized to get TAVI with SAPIEN 3 or SAPIEN 3 Ultra versus surgery. And they follow the primary outcome. The characteristic is quite similar to this patient. In the trial, the mean age is 74. 20% had concomitant coronary artery disease. The LVEF was normal. And again, many people have small annuli. In this trial, they use in the TAVI, they use SAPIEN 3 and SAPIEN 3 Ultra. And we got the answer that, in women, as I think, when the patient gets TAVI, they do a lot better compared with surgery. The rate of death, stroke, and rehospitalization is 8.9% in the TAVI arm, compared with surgical harm has an event of 15.6%. So I think, women do a lot better with TAVI compared with surgery. There's a little trade-off when we use SAPIEN or SAPIEN 3 compared with surgery in women. I think hemodynamic profile is a little better in surgical arm. In surgical arm, they got less mean gradient and get more effective orifice. Severe patient prosthetic mismatch occur more in TAVI, 7.2%, compared with surgery that got only 2.6%. So that's why I think, we got the first answer. TAVI is better, but, we have to be careful a little bit about hemodynamics performance after TAVI. What about self-expandable? Is it better, in small annuli compared with balloon expandable? So I think, I want to discuss a little bit about SMART trial that started CVAS with small annuli. It is a randomized control trial to randomize the patient to get either Medtronic self-expandable valve versus Edwards SAPIEN balloon expandable valve, and they got 2 co-primary endpoints. The first co-primary endpoint, they are the same in the term of death, stroke, or heart failure hospitalization. The events are the same. Either they got Evolut or SAPIEN. On the other hand, the co-primary endpoint, it is bioprosthetic valve dysfunction. It favors Evolut. However, it is driven by hemodynamic significant structural valve dysfunction and valvular leak that occur more in SAPIEN arm. But keep in mind that hemodynamic structural valve dysfunction, the definition is different than WAP 3 criteria that we use right now. Sounds like, we should use more self-expandable in small annuli. However, when they follow the patient through 2 years, the clinical event is not different between SAPIEN and Evolut. So I think my personal conclusion is you get more hemodynamics data with Evolut, but the clinical endpoint remains the same in both groups, and the graph is overlapping. There is no signal for diversion at all. So I think some answer cannot get from RCT yet, but in my routine practice is, to see if there is any issue if we use self-expandable. Like I mentioned before, in this patient, she has concomitant coronary artery disease, and she's quite young. She might do. We might need TAF in TAF. That's why I think virtual valve is very important in a case like this. If we use SAPIEN number 20, it will be super easy to engage coronary artery because the left coronary artery and right coronary artery takeoff are higher than the stent frame. Also, it will be feasible to do TAF in TAF if we use SAPIEN 3 number 20. On the other hand, if we use Evolut 3, we might have a to engage coronary artery or to do TAF in TAF. I think if we use Evolut, first of all, you have to align the commissure and you might have to deploy the valve a little deeper than normally do. But keep in mind that the membranous septum is only 1.3 millimeter. It is very high risk to develop complete heart block if you deploy Evolut too low. So from this point, I would personally, I favor SAPIEN 3 number 20 because I think for coronary access and TAF in TAF, they are feasible if I use SAPIEN number 20. The last question that I have to answer is if it is big enough for this patient. So I use this. So I use this graph, to see if the patient will get patient prosthetic mismatch or not. And when the patient has BSA 0.15, using SAPIEN 20 is still okay. If the patient has BFA of like 0.7 or 1.7 or 1.8, I would start to get worried a little bit. But BSA 1.5 with SAPIEN 20 in small elderly type patients, I think it is okay. They will not get severe patient prosthetic mismatch. Then, the last question is about coronary artery disease. Should we do it or not? So I think I think many people would fix just aortic valve and treat coronary artery medically. But I think the data from Notion 3 trial give us the different idea. This is a study that randomized the patient to get either PCI or medical treatment and follow the patient. But they enroll the patients if they have severe aortic stenosis plus coronary artery disease with FFR 0.8 or less, or diameter stenosis 90% or more. So it is quite severe coronary artery disease. And the patient who underwent PCI did better compared with medical treatment that has less composite endpoint of all-cause mortality, MI or urgent revascularization. And the result is mainly driven by MI and urgent revascularization reduction. So in our practice, if the stenosis is very severe, we do PCI after TAVI. So this is my conclusion, my plan for this patient. So I'll 75 years old, otherwise healthy, suitable for TAVI, I would recommend transfemoral TAVI. And in this case, I would use SAPIEN 3 Ultra number 20. Like I said, from the data from Notion trial, I would do PCI, but I would do PCI later. I would fix aortic valve first. I would do PCI before TAVI in the case of severe left main coronary artery disease or proximal LAD or severe triple vessel disease. But in a case like this, 90% mid-LAD lesion, I would do it after TAVI. In our center, we prefer minimalist approach, conscious sedation, transthoracic echo, and LV wire pacing. From the data right now and with the reimbursement problem in Thailand, I would not use cerebral embolic protection device in this case. Normally with SAPIEN, I would do with direct deployment, but the patient has moderate calcification and very, very critical CVAS. I would do predilatation with balloon number 20, but I know that some implanter might not. And I would use overfill 1.5 cc and try to aim high to keep the patient away from pacemaker implantation. Thank you very much.
Thank you, Narati, for your comprehensive talk. Thank you very much for the comprehensive talk and sharing your decision-making process of these patients. I want to see whether they have questions to your talk. Okay. For this patient, actually, you introduce all the possibility of surgical choice or TAVI choice very comprehensively. I appreciate all the presentation you have. Actually, the patient actually is 75 years old woman, not quite old, not quite young, in between, but the decision making of your choice actually very comprehensive and including all the possibility that we think about this. So it's a nice demonstration of how we deal with the TAVI patients. And I saw one slide that I was not quite understand is that you mean in women when we do the TAVI, actually the bioprocesses deterioration, they have some difference in self-expandable and balloon expandable. Is that the slide shows? Is that I realize? Could you make some comments about this?
Yes, I think, because especially in Thai women, like I would say like more than 2/3 of Thai women, you have small annuli by Western definition. And I think, we are seeing in the same situation in Japan, in Ocean registry that, in a small Asian women, they will have small annuli. But I think right now the evidence that the clinical endpoint is the same between balloon expandable and self-expandable. But, the echo measurement favors self-expandable because of the SAPIEN design. It tends to have higher gradient. And a part of that is, I think, there are two parts. I think, first of all, self-expandable has a bigger EOA, and I think that's the truth. But on the other hand, the design of SAPIEN has pressure recovery phenomenon because of the design of the valve that we see a lot in small valve in SAPIEN number 20. Because I still have I had some cases that my echo colleague show echo gradient like 30 the next day, but in the cath lab I got like no gradient, and I brought the patient back to do stage PCI, and then I do invasive pressure measurement. In that case, like the gradient across the valve is less than 10. That got some mid cavity gradient, they got some pressure recovery, and then that makes the gradient higher. So I think I think that's two things. I believe that EOA is a little bit better with self-expandable, but still you have to take a pressure recovery phenomenon into consideration when you use small sapien. But at the end, from SMART trial, 2-year follow-up, the clinical endpoint is not different.
Okay, thank you very much. And one more, my personal question is that the patient actually had coronary disease, about 70% of stenosis, right? But if we met a patient who had a significant coronary stenosis, like 90% stenosis over LAD territory, when you do the TAVI, will you do the coronary stent first, or you will put the TAVI first, then to see what happens in the future?
So if it is 90% proximal LAD straightforward, I would do PCI first. But if it is complex lesion, like heavily calcified lesion that I have to do rotational arthrectomy, I would do I would do PCI later, because I think TAVI in tricuspid aortic valve right now might be easier than complex PCI in some situation. And in that case, I would use the valve that I can access coronary artery easily, either short frame balloon expandable or cells expandable that have bigger cells.
Okay, I understand. Thank you very much. Thank you again for your wonderful talk. And because of the time reason, we have to move to the next and the final talk. Thank you very much.
Thank you.
And the final talk will be delivered from Jihad Ramahi. He works in Abu Dhabi, and he will talk about severe aortic regurgitation for SAFA, my strategy thinking. Rahari, please, it's your time.
Seems Dr. Ramahi is not
Not here.
did not get a 9.
I didn't see.
No, he's not online. He's
not online. Okay.
Yeah,
okay.
sorry.
Okay. So
Okay.
okay. That's okay. So we have today we have talks about intervention from rheumatic heart disease, PDMV, and for primary mitral regurgitation, we have mitral tear and functional mitral regurgitation, and all covered by mitral clip. And finally, we have bicuspid aortic regurgitation, aortic stenosis, and tricuspid aortic stenosis using TAVI. Cover all those procedures. And we have comprehensive discussion about those topics. I can finalize those things because right now all interventions cover almost all kinds of valve disease, but we still have room from surgical field. Thank you all the speakers and attendees that we have a comprehensive talk and discussions today. If there's no more questions, probably we can finalize it. And thank you again for your participation. Thank you very much.
Thank you all. Thank you all of you. Thank you for great contribution. Yeah. I think we will not wait for Dr. Jihad. I think he's not online, I know. And maybe it's a connection problem. But thank you for all your great contribution. It's a very interesting talk. And thank you for always achieve surgical point of view to this more interventional section.
Thank you very much. Thank you for the invitation.
Okay, thank you. And we'll close the section. Thank you all. Bye-bye.
Bye bye.